Assalamu alaikum. Let's discuss about a very high yield topic, that is intussusception. Intussusception. What we need to remember in intussusception. In intussusception means telescoping of one bowel segment into the adjacent segment, most commonly ileocecal. So, telescoping of one bowel segment into adjacent segment, most commonly ileocecal. So, telescoping. And in intussusception, if we do the ultrasonography, we can see the target sign. So intussusception targets. It can cause bowel edema, which leads to ischemia and necrosis. And intussusception age group is 6 months to 3 years is very common. 6 months to 3 years is common. Risk factor is hypertrophy of the intestinal Pierce patches, recent viral infection. Pathologic lead point is Meckel's diverticulum, Henoch-Schönlein purpura, intestinal tumor. Clinical presentation, there is sudden, intermittent abdominal pain and vomiting. There is sudden, intermittent abdominal pain and vomiting. There is a sausage-shaped mass in the right abdomen. So sausage-shaped mass, sausage-shaped mass, and the stool is red currant, currant jelly stool. And status, that means mental status, is altered or there may be lethargy. And for diagnosing, if we do the ultrasonogram, there may be target sign. On ultrasonogram, there may be target sign. And as a treatment, we can give as a treatment we can give pneumatic or saline edema, pneumatic or saline edema, and surgical intervention for failed edema reduction and signs of peritonitis. If there is signs of peritonitis means pneumoperitoneum, that means free air under the diaphragm, free air under the right dome of the diaphragm or maybe the left dome of the diaphragm. It is the signs of peritonitis. And in on ultrasonography, there is target sign or also known as bullseye sign is present in case of intussusception. And contraindication, like if somebody has history of intussusception, rotavirus vaccine, rotavirus vaccine cannot be given. Okay, barium contrast enema is generally avoided in patients with suspected intussusception due to risk of this peritonitis if perforation occurs. Laparotomy is indicated if enema reduction is ineffective, if a pathologic lead point is identified, or if the patient has signs and symptoms of perforation, free air on the diaphragm or rigid abdomen. Most common is 6 to 36 months. We know that a pathologic lead point should be suspected in patients with intussusception. There may be recurrent episode, atypical rotation, small bowel into small bowel, atypical age, atypical location, persistent rectal bleeding despite reduction. The most common lead point is Meckel's diverticulum, and it is diagnosed via nuclear scintigraphy. If we look at this ileocholic intussusception, there is ileum, there is colon, looks like target lesion or bullseye lesion. This is the another picture of the intussusception abdominal X-ray where there is crescent sign. This is the crescent sign. This is the crescent sign. Edge of intussusception projecting into gas filled lumen. Edge of intussusception projecting into gas filled lumen. So, for intussusception, we need to look at the risk factor like first of all age 6 to 36 months. There may be prior intussusception and recent intestinal infection and underlying disorder. These are the pathologic lead point like Michel's diverticulum. There may be Henoch-Schönlein purpura. There may be cystic fibrosis. These are the things we should be kept in our consideration. And in this clinical scenario, there is severe intermittent abdominal pain that lasts for 15 to 20 minutes. So this pattern follows actually like alternates with pain-free episodes. So there is pain episode and pain-free episode when bowel is not contracting. So there is pain-free episode, and when bowel there is peristalsis, there is pain episodes. There may be sausage-shaped mass that may occasionally be palpable in the right side of the abdomen. There may be blood in the stool. There may be episodes of lethargy. If we look, if we find a case with intussusception, what are the differential should exclude? What are the DDs should be excluded? The DD should be excluded first gastroenteritis, one of the differential. Second is appendicitis, gastroenteritis, appendicitis. There may be incarcerated inguinal hernia. There may be volvulus. There may be Michel's diverticulum. There may be volvulus. There may be Michel's diverticulum. These are the differential we should exclude for diagnosing intussusception. Then we do some investigation like abdominal ultrasonography can be done. Mm, and on ultrasonography, we got this target sign, and as a treatment, we can use air or saline edema. And for treatment, mm, surgical intervention for failed enema reduction. And complication and prognosis is it can recurrence can happen and bowel perforation can happen. Recurrence can happen and bowel perforation can happen. So this is all about intussusception. Hope you enjoy.